I'm Reuben Strayer. I'm an emergency doc working in Brooklyn. It's such a pleasure to be back in person in beautiful Vegas with all of you beautiful people. I've only got 10 minutes, so we're going to hold on to small talk. Let's jump right into aortic dissection. Aortic dissection is one of a small but very important set of conditions that qualify as a true emergency, which is to say that it's dangerous, time-sensitive, and treatable. We in emergency medicine spend a lot of time focused on the list of true emergencies. This is only a partial list. And I would submit that among the true emergencies, there is no truer emergency than aortic dissection, which carries a 40% mortality on presentation that increases by 1% per hour and has specific medical and surgical treatments that are effective if administered early enough. Aortic dissection is often described as rare, but although it's not common like ACS and PE, it is not rare. I've seen at least a dozen cases in my career of however many years it's been. You will see it. And it often occurs in relatively young, otherwise healthy people. So the stakes are high, and there are many famous cases like John Ritter and Lucille Ball and Jonathan Larson, who wrote the musical Rent and died of aortic dissection at the age of 35, the day before Rent was to open on Broadway, after visiting several emergency departments with chest pain, shortness of breath, and dizziness, and being diagnosed with influenza and stress reaction. And then of particular sadness to folks in my generation, Andy Fletcher, the keyboardist for Depeche Mode, just died of aortic dissection a few months ago at age 60. The diagnosis of aortic dissection is very easy, but also very hard. It's very easy because there is a single excellent test, CT angiography of the aorta, which is easy to do, it's widely available, but there are harms. And in some departments, it's a scarce resource and it's not routinely done. So who needs the test? Who needs this excellent test, CT angio aorta? That is the question. It is the question for emergency medicine, because if the test is negative, you're done. And if the test is positive, then the management of the aortic dissection is actually pretty straightforward, as we'll discuss later. So the question for emergency medicine is, who needs CT aorta? That is the test, that is the most important question around the entire issue of aortic dissection. And it's a hard question, because most patients who present, at least initially, with aortic dissection do not have features for dissection. The aorta perfuses every organ in the body, and aortic dissection can therefore cause any symptom. And in patients who present with atypical features, without specific features for dissection, the clinician is appropriately focused on more common causes of the patient's symptoms, often more common dangerous causes like ACS and PE. So dissection is not just a needle in a haystack. It is a needle in the shape of a blade of hay in a haystack, which is why the vascular surgeon, who is considered the authority on this disease, says that the standard of care is to miss it. So in patients who have dissection but present without features for dissection, you are going to miss the diagnosis, and you have to be comfortable with that. Because if you tried to pick up those patients, you would have to scan everyone, and that would cause vastly more harm than good. But there are patients who need the test, where not doing the test would be a mistake, a potentially very consequential mistake. And this slide is the most important slide because it tells you who those patients are. They're patients with chest pain or back pain, and any of these features. If you have one of these features, you should strongly consider doing CT aortography. And if there are two features, if your patient has two of these features, you need a very good reason not to do CT aortography. These features are based in part on the ADD risk score, which is all over the literature, but the literature also tells us that you cannot rely on the ADD risk score. It's not accurate enough, it's not good enough to use as an open and shut pathway. ACEP has a clinical policy stipulating that you can't use the ADD risk score as an open and shut pathway, which is why I'm not talking about it. Some patients who have dissection will present very unwell or with a sense of doom, which is justified, and that's going to raise your suspicion. But many patients with dissection, especially early in the disease course, which is when you want to pick it up, present stable and well. I'm not sure why it is so commonly believed that dissection patients have to be clinically toxic. It is not so. Do not be reassured by a well-appearing patient with features for dissection. Do not doubt dissection because the vitals are normal. That would be like doubting subarachnoid because the vitals are normal. Aortic dissection has a lot in common with subarachnoid. It's kind of like subarachnoid of the chest. A negative dimer does lower your post-test probability for dissection, but it, unlike pulmonary embolism, doesn't exclude it. And of course, false positive dimers are very common. So until and unless there's a validated, recommended pathway that incorporates a dimer, at the moment, there really is no role for using a dimer in deciding who needs a scan. I think that the reason that patients who have dissection features are missed by emergency clinicians is because emergency clinicians often have ACS blinders on when they're evaluating chest pain, that their evaluation of chest pain begins and ends with acute coronary syndrome. And that's also a mistake. There are, by my count, 7 dangerous causes of chest pain. This evaluation pathway, which is available at emupdates.com/CP for chest pain, reminds you to consider all 7 dangerous causes of chest pain. So this is my concluding slide. I'm bringing back the most important slide, which is the features of aortic dissection. And I'm going to conclude with 2 points. The first is that you are going to miss cases of dissection that do not have features of dissection. And that is appropriate, good care, because if you try to pick them up, you would have to scan everyone, which would cause vastly more harm than good. But know the features for dissection, or have a list of them handy. Usually, 1 is all you need, but certainly if there are 2 or more of these features, exclude the disease with CT aortography. Thanks very much.